Good morning. Today we'll be doing 200 MCQs about orthodontics. The first question is, the rectangular wire used in edgewise appliance is primarily meant for? The answer is correction of crown and root position. Now, usually when you put a rectangular wire, it sits in the slot in such a way that it angulates the crown and the root position to the final position that is supposed to be in the arch. The second question is, the buccal coil spring is used to regain the space between the first premolar and the first molar. And what is the most common complication occurring post-treatment? The answer is the rotation of the first premolar. Now, usually this happens because since the premolar is slightly smaller and the roots are a little more slender than the molar, and the molar is able to take up all these forces, usually any kind of rotational forces that occur, it falls on the premolar itself. So these are some of the examples of that. Although this is a picture of a transposition of the canine and the premolar, but anyways. Second is, this is a lateral cephalometric analysis, and which is the percentage of magnification which is seen in this image. In this case, it is 7 to 12%. Now, usually what happens is, when you take a lateral cephalogram of a patient, there is some kind of image magnification happening. So, the least amount of magnification occurs in the midline, and the maximum amount of magnification occurs in the structure that is away from the midline. So, the axial tooth inclinations and the dentoalveolar relationships in the midline of the jaws, here is where mainly the magnification occurs. Fourth one is, which of the following face types is associated with mouth breathing? The answer is dolichocephalic. Now, dolichocephalic means a little longer face. So what happens is, in longer face syndrome, there are these typical characteristic adenoid faces in which there's a flaccid upper lip and there's a constricted upper arch, and also marginal gingivitis is seen. These patients also suffer with mouth breathing and therefore incompetent lips, among other features seen in a long face patient. Which of the following orthodontic technique can be used to treat class 3 malocclusion? The answer is D, that is A and B, Lefort 1 osteotomy for the maxilla and BSSO for the mandible. So, this kind of a orthodontic surgery can be done in patients who have a maxillary setback as well as a mandibular protrusion. Not for all cases, because there might be some cases in which maxillary setback is not happening, it's only a mandibular protrusion. So, this is in particularly those kind of cases. Next is, the center of rotation at infinity is seen in which of the following? The answer is D, translation. Now, this is a part of biomechanics. When we talk about center of rotation, center of resistance, when the translatory movement is seen, that means that the tooth is moving bodily from one position to another position. It is not just tipping in which the crown and root are moving in opposite directions, it is a bodily movement. Hence, the line passing through the center of rotation and through the center of resistance is such that these two lines are parallel, and that can only happen when they meet at infinity. Therefore, when we talk about translation as in bodily movement of teeth, the center of rotation and resistance meet at infinity. When we talk about controlled tipping or uncontrolled tipping, the center of rotation and the center of resistance are at different points, such that when you put lines through them, they meet either at the root tip or the crown tip, depending upon what kind of tipping happens. The lowest most anterior point on the alveolar bone in the midline between upper central incisors is called the supradentale. Now, these are different points on the lateral cephalogram. The first one is basion. Basion is the median point on the anterior margin of the foramen magnum. It is more appreciated when you see an anterior posterior view or anterior posterior radiograph, or even if you see a skull from the behind. When you see the lower margin of the foramen magnum, the median point of that is the basion. The Bolton's point is the highest point on the postcondylar notch of the occipital bone. That is not very well appreciated in this lateral cephalogram, because that is a point which has to be made in the lateral cephalogram. It is not a normal anatomic point. The third one is misspelled, is actually porion. Porion is the highest bony point on the upper margin of the external auditory meatus. It is one of the very important points through which a lot of reference lines can be made for cephalometric analysis. Again, gonion, menton, prostheon, these are points on the alveolar bone. Gonion is a point on the junction of the ramal plane and the mandibular plane. Again, this is a constructed point. It is not an anatomical point. The menton is the most inferior midline point on the mandibular symphysis. This is an anatomic point. And the prostheon is the lowest and most anterior point on the alveolar bone in the midline between the upper central incisors. This is yet again another anatomic point. Which of the following cephalometric points can be altered by orthodontic tooth movement? The answer is point A. Now that happens why? Because as you see, the point A is the deepest point on the curve between just in front of the roots of the central incisors. So once the tooth moves, there is some amount of bone remodeling also happening. Therefore, this point A is dependent on the position of the central incisors. So once after orthodontic tooth movement or orthodontic treatment is completed, the point A 100% usually changes. Now, which cephalometric point represents the center of the ramus of the mandible? The answer is A. Now, this is called XI point. You can also call it as Xi point, however you would like it. This point is a constructed point. We have to construct it using 4 planes. One on the lower border of the margin, anterior and posterior borders, and the ramal plane. Where all these 4 borders, they come together intersection in the middle of the ramus, that is the XI point. Now, this is usually used in the little more complicated cephalometric analysis. Next is, which of the following is the simplest type of tooth movement? The answer is C. Now, tipping tooth movement is the simplest because not only can it be done by a fixed appliance, it can also be done by a removable appliance. In fact, removable appliances mainly have their action by tipping. Translation is a very difficult movement which is usually done in a fixed appliance. Torquing again needs a fixed appliance, and control tipping is another part of tipping. Next is the sensitive 4-ounce Dontrix gauge used to determine force applied. By which of the following methods? The answer is an elastic. Now, the Dontrix gauge is a gauge which is used to determine the amount of force that is applied either within the mouth of the patient or any kind of orthodontic appliance. So, what you do is, one end you can engage it to the particular appliance that you want, and then you apply an elastic and you stretch it. So, according to the amount of force that is applied, that force is seen on the measurements on the Dontrix gauge, and it is measured in ounces. So, the minimum measurement that you can see here is around 4 ounce. So, this kind of gauge is used to measure coil springs or elastics, intraoral elastics. That is used mainly, it started with the Begg technique. Next is, which of the following can be used for determining skeletal maturity of an individual? The answer is all. There are hand wrist radiographs, there are cervical vertebrae radiographs, and also tooth left abutment. Now, we cannot say that there is only one particular method which is foolproof or which is completely reliable. So, but nowadays cervical vertebrae is usually mainly used routinely. The rest can be used as accessory methods. So, these are the different ways in which you can assess the developmental age based on the kind of method that you would like. Next one is, which of the following malocclusion is characterized by presence of the lower incisors behind the upper, I think centrals is the word. The answer is class 2 division 2 malocclusion. Now, basically this kind of malocclusion is characterized by deeply locked in lower central incisors. There is almost a close bite or a very, very deep bite. So, it kind of, what happens is the maxilla locks in the mandible, therefore it inhibits the further growth of the mandible. That is why there is a characteristic typical class 2 kind of mandibular growth that is seen in this kind of case. Next is, in case there is an edge relationship, the question is a little wrong. There is an edge to edge relationship in which of the following? The answer is C, that is middle third of the root. This I could not understand. There is something wrong with the question and the answer. Okay. A developing malocclusion can be intercepted and prevented best at which age group? The answer is C, that is 7 to 10 years. Now, why? Usually because the centrals have erupted, laterals have erupted, canines are about to erupt, and premolars are just about reaching the stage where you can see them coming into the oral cavity. Now, here there are a lot of kind of interceptive orthodontics that also can be used. So, it is best to start treatment at this age, but the formal kind of full-fledged orthodontic fixed treatment can only be done at around 12 to 13 years once all the teeth have erupted. But interceptional orthodontics can be done at this stage. Flush terminal plane deciduous teeth is expected to cause which of the following relationships in a permanent dentition? The answer is class 1. As you can see, flush terminal plane means that the distal end of both the cusps, when you draw a straight line, they both meet. Now, what happens because of the transition period happening in the mixed dentition, that the deciduous teeth shed and the permanent teeth start erupting, there is some amount of movement happening, and usually a flush terminal plane most of the times leads to a class 1 relationship. Whereas a distal step leads to class 2, mesial step leads to class 3, so on and so forth, something like that. Early mesial shift occurs by utilization of which of the following? The answer is primate space. Now, primate spaces are mainly found between the lateral and the canine in the deciduous dentition. So, as you see this flush terminal plane, there are two possibilities. Either you get an end-to-end relationship or you get a class 1. Now, end-on relationship is usually not very stable. So, what happens is it doesn't really stay at this position for a very long time. Maybe for a slight amount of time it can stay over there, but ultimately it either goes to a more stable position, that is a class 1. The same way, mesial step either leads to a class 1 or it leads to a class 3. But in both cases, either class 1 or class 3, both are stable. Only the end-to-end relationship is not a very stable relationship. So, that is something which we don't usually see very common. All of the following parts of the mandible shows endochondral growth except the symphyseal region. Now, in the symphyseal region, there is in the cranial base you see synchondrosis, and the nasal septum, corona and condylar processes you see intramembranous development, and the rest of the whereas the cranial vault and maxilla and rest of the mandible you see sutural growth development. Second, tooth resorption due to undermining resorption starts after 7 to 14 days. Now, undermining resorption mainly occurs when there is a very heavy amount of orthodontic tooth movement, or very heavy forces are supplied over a very short period of time. There is too much of pressure on the periodontal ligament. There is in fact almost some kind of necrosis happening because there is pressure on the blood vessels. The fluids ooze out of the blood vessels, and hence this kind of undermining resorption occurs. Now, this is not a very desirable thing that we need in orthodontic movement, because it leads to unnecessarily mobility of the teeth. So, that is why we say that during a fixed orthodontic treatment, the force that is applied to the tooth should be the optimal force that is required for the tooth, and not such that causes undermining tooth resorption. Can you tell me when should I stop, or because I can go on like this? Area of hyalinization is seen in which of the following? The answer is in undermining resorption. Because of the histological appearance as a cell disappear, when you see an area of hyalinization, it is slightly bluish in appearance, and this avascular area in the pedial is referred to as a hyalinized area. The best point to register the template over the patient's cephalogram for tracing growth in cases with difference in cranial base length is nasion. Now, nasion is one of the most stable points in a cephalogram, because very little amount of change as far as resorption or remodeling occurs in that place. So, when you take a cephalogram over different periods of time, let's say in a difference of 1 year, 2 years, 3 years, 5 years, it is one of the registration points where you can place superimpose couple of cephalograms and see the changes that have been happening in other points. For example, previously we talked about point A. and the resorption happening in point A and the change in position of point A. So if you want to see a change in one point, you have to take one reference point, keep that as stable and see the changes occurring in the other points which can be changed. So nasion is one of those points which are more stable in the skull. So the cranial base superimposition, it allows the relationship of the maxilla and mandible to be evaluated. So in general, the most useful approach is the SN line registering over the template. So when you take the SN line passing through the sella and the nasion, that reference line is the most stable, and among that the nasion is the most stable. Why? Because another thing is that the sella also might undergo a couple of changes. Compared to that, the nasion is a little more stable point. While superimposing cephalograms, which of the following is superimposed first? The answer is the cranial base. Now again, for the same reasons that the cranial base line goes through 2 points which are the most or rather the least changing, that is one of the reasons why we take the reference point as the basal plane, so that changes in the lateral cephalogram over a period of time or because of treatment can be visualized much better and more accurately also. According to Ackerman Profit's classification, malocclusion, which of the following is considered the transverse deviation of occlusion? It is called crossbite. Now, when you take an anterior posterior plane, it is like this. When you take a horizontal plane, it is like this, and this is the transverse plane. So the answer is crossbite. All of the following are the median cephalometric points except porion. Median again is in the midline. So sella is in the midline when you see it anterior posteriorly. ANS again is the midline. Porion is also not exactly in the midline. So that is why the answer is the porion. Increase in length of the orthodontic wire causes all the following except decreased springiness of the wire. Usually we don't see an increase in length of the orthodontic wire as such, but when you put it in a patient's mouth and because of the temperature of the mouth, a little bit of flexibility occurs, and because of that the springiness increases. So increase in length causes anything except decrease of springiness of the wire. The increase in length of the wire causes increases of range in action, decreased stiffness and reduce of the force applied. Which of the following is the most common form of malocclusion? Usually you see class A, now class 1. Now in class 1 itself there are many variations of class 1. You can have class 1 with bimaxillary protrusion, you can have class 1 with spacing, class 1 with crowding. Therefore class 1 is the most widely seen malocclusion in any kind of a population. Oxygen tension alteration in PDL cells occurs after application of light pressure, just in a matter of minutes. So this kind of change that occurs when the moment you put an orthodontic wire usually occurs in minutes. So the light pressure means that when you apply a force, it is either in a couple of seconds, and heavy pressure causes changes even in less than a second or so. Can I stop now? Is this alright or should I carry on? 10 minutes more? Okay. Protraction face mask derives anchorage from which of the following regions? It is the facial bone. Now here this is a reverse pull face mask. This is mainly used in a class 3 patient with a maxillary setback and a mandibular protrusion. So what you do is it gains anchorage from the forehead region that is here and a chin cup which is here. There is elastics which are attached to the a hook which is placed in the premolar canine region, and these are attached to the main frame. So what happens is these elastics make the maxilla grow forward outward, and there is a reciprocal push on the mandible inside because of the chin cap region over here. This is a form of an extraoral anchorage which is taken from the forehead and also from the chin. Heterogeneous population shows incidence of malocclusion as compared to homogeneous population. A heterogeneous population will show a higher incidence of malocclusion compared to homogeneous population. Again, why? Because when you take people belonging to different races, cultures, areas, countries, ethnicities, religion, they are going to have their particular type of malocclusion. So when inbreeding occurs between different sects of people, you will see a completely different malocclusion occurring in the offspring or in the next generation, as compared to when you take people of the same culture and community inbreeding within themselves. The same kind of malocclusion will be seen passing on to the next generation. There will not be much of a change because the genetic pool is decreasing further and further. If you take a heterogeneous population, you will see a mixture of genetic codes and genetic populations and pools happening all over from different areas. So you might actually come up with a completely different pattern of a malocclusion in the offspring. So you will actually see a high incidence of malocclusion occurring in heterogeneous populations. Growth of maxilla first is completed in which of the following planes? The first is width, and then after that is depth, and then finally height. Maxillary midline diastema is more than so and so millimeter, rarely closes spontaneously, that is 4 millimeters. Usually 1 or 2 millimeters is something which can be seen either day to day wise, and it might happen because of many reasons like a very low frenal attachment or something like that, and sometimes just removal of the frenum as in frenectomy can also spontaneously close the diastema. But something more than 4 millimeters or 5 millimeters would need some kind of orthodontic correction. The normal value of y-axis in cephalometric analysis is 60 degrees. This does not show the y-axis actually. The y-axis is also called the growth axis. When you want to figure out the growth pattern of an individual, you draw the y-axis. Depending upon the angle the y-axis makes, you can figure out whether this person is a vertical grower or a horizontal grower. That also determines the kind of a facial pattern of the patient. Which of the following is the most important preventive and interceptive orthodontic procedure? It is restoring deciduous teeth. Now, preventive and interceptive orthodontic procedures are they have very little bit of difference. We do a preventive orthodontic procedure before the actual malocclusion actually develops. So, preventive orthodontics is mainly done in the deciduous dentition. Therefore, restoring deciduous teeth. If you restore deciduous teeth, like suppose there is a very badly decayed molar or something like that, if we restore it, then there are chances that the other teeth will not drift into that position, hence malocclusion will not occur, hence the arch width might not decrease, those kind of things. When we talk about interceptive orthodontic procedures, that means some part of the malocclusion or problem has already set in. We are trying to stop it at that position so that it doesn't become worse. Interceptive orthodontics includes serial extraction, whereas preventive orthodontics includes restoring deciduous teeth. A pontic type of space maintainer can be classified as which of the following types? It is functional. Why? Because a non-functional one usually would not use a crown. It would just be a band and a loop. When you talk about functional, it means it gives function to the arch. So when you put a crown, that means that you are replacing the tooth with a normal, almost anatomical tooth structure. So the function of chewing, mastication, talking, etc., those things are restored to normal. So that is why one with the crown is used, is called a functional space maintainer. Hyperactive mentalis activity is characteristic feature of which of the following types of malocclusion? It is class 2 division 2. Again, previously what we had discussed, in class 2 division 2, the lower incisors are completely locked under the upper incisors. There is almost a complete or a close bite, because of which the mentalis muscle activity is extremely high. According to Andrew's 6 keys of normal occlusion, which of the following is advisable for ideal occlusion? The answer is gingival part of the long axis must be distal to the occlusal part. Now this diagram is exactly not explaining this kind of a key, but when you take the long axis of the crown and when you take the gingival part, that is the highest point, that should be distal. That means that the tooth is not exactly straight in the jaw. It is slightly curved. There is slight amount of inclination and angulation that is present in each and every tooth, and it varies according to the position of the tooth or the type of tooth that is present. So you will not see a tooth standing absolutely straight like this. There is an amount of inclination that occurs in each and every tooth. Which of the following is the best representative natural orientation of the skull? The answer is the FH plane. Now the FH plane is called the Frankfurt horizontal. It passes through the porion and the orbital in this part. Now this is the best representative natural orientation of the skull. Why? Because when you ask a person to stand straight and look straight, this Frankfurt horizontal is parallel to the floor. So this is the most natural position in which you can orient a person without having to physically alter the position of the head. Even when you take a lateral cephalogram in your radiology area or when you're taking it, this is the plane that is most acceptable, because the rest of the planes it is difficult to get. So without actually tracing or having any kind of points or any kind of landmarks or guidelines, we can obtain this position very easily on a patient just by standing and looking straight. Baker's anchorage is an example of which of the following? The answer is intermaxillary anchorage. Now, intramaxillary means within the maxilla, that means within the arch. Intermaxillary means between two arches. So, in this case, this is the example of a class 3 elastic. It uses a reciprocal force. That means it is pulling one arch and it is pushing the other arch. So, this kind of reciprocal anchorage is called Baker's anchorage. Maximum anchorage cases allow how much of space loss? That is less than 1/4. That means almost 25%. When we talk about anchorage, there is minimum, moderate and maximum anchorage cases. Now anchorage means what? We are trying to, anchor is nothing but something which we hold on to, so that suppose we are swimming in a pool or in a sea, you see these little anchors in between. So the anchors help or rather stop us from drifting to an unnecessary position. The same way, molars are the anchor teeth. So they stop the rest of the teeth to drift into a position where they are not supposed to. So when you do an extraction, suppose we remove the first premolars, we like to bring the anterior teeth behind. So we use the molars as an anchorage so that the anterior teeth don't start moving in front or in any other direction. So when you have a maximum anchorage case, that means you want maximum amount of anchorage and minimum amount of unnecessary tooth movement, that is called a maximum anchorage case. So space loss, that means unnecessary loss of space which we do not require, should be minimum, which is less than 1/4 or less than 25%. In case of single rooted teeth, the center of resistance is located at which of the following locations? It is located at the junction of the cervical and middle 1/3. In multi-rooted teeth, it is in a different position. Generally, the center of resistance is constant. It is the center of rotation that changes. In a single root, it lies between the cervical 1/3 to half of the root, apical to the alveolar crest. While in multi-rooted teeth, the center of resistance lies between the roots 1 to 2 mm apical to the furcation area. The longer the root, the more apical the center of resistance is. That means more towards the root tip. And the higher the alveolar crest, the more coronal the center of resistance. Prolonged retention is required in all of the following cases except blocked out canines. In a midline diastema, it is almost always 100% necessary because of the fibers, the gingival fibers that are present. They tend to again, increase the space and pull back the teeth. Class 2 division cases and deep bite cases almost for the same reason. But in blocked out canines, usually once the canines come down to the normal positions, the incidence or the percentage of relapse is almost very negligible. So in these kind of cases, prolonged retention is not really required. The amount of incisal liability in the maxillary arch is 7 millimeters. Now, incisor liability is nothing but the extra space, that is the difference between the space occupied by the incisors, the primary dentition and the permanent dentition. Since the permanent incisors are much larger than the detritus incisors, when the detritus incisors shed and the permanent incisors erupt, this amount of extra space is called the liability, and it's about 7 millimeters in the maxillary arch and 5 millimeters in the mandibular arch. Spaces existing between deciduous teeth are called developmental spaces. Primate and simian spaces are nothing but the same. Developmental spaces are usually present in all children. In case developmental spaces are not present in a particular child, one must think that in future this child, the possibility of this child having malocclusion is going to be very high, because these spaces usually help the child's permanent dentition to settle in a correct position. And if these spaces are not present, usually there is a arch form tooth material discrepancy. Functional shift of mandible due to eruption of the permanent teeth causes deviation in which of the following directions? That is transverse dimension and anterior-posterior dimension. Because especially when there is an impacted tooth and that does not erupt properly, there is some amount of mesial movement or mesial tilting of the 6s and the 7s. Therefore, the shift of the mandible, that is in the transverse direction, occurs. Anterior posteriorly also, because this again leads to some amount of crowding of the anterior teeth, that happens. Sucking habit tends to produce constriction in which of the following regions of the dentition? It is not only in the maxillary canine region, but basically in the entire anterior maxillary region. Why? Because when sucking happens, especially when it is a part of a habit in older children also, the thumb, the base of the thumb is placed right behind the upper central incisors. So you tend to push the anterior maxillary region forward and it creates a kind of a V shape for the arch. So instead of the arch becoming U-shaped, it becomes V-shaped because there's a constant force being applied to the upper central incisors. Apart from that, there is also open bite because of the complete tongue thrust and also the kind of thumb sucking habit. You might also find a unilateral or sometimes a bilateral crossbite also. Threshold force duration in humans for tooth movement is 6 hours. Because usually this is the minimum amount of time that is required for the force to be applied on the tooth and finally the tooth to start moving. Again, undermining resorption causes tooth movement in about 7 to 14 days after the force is applied. Next is 100% chances of successful opening of the palatal sutures are seen until the age of 15, because usually after that age there is ossification, and if you want to do any kind of splitting of the palatal sutures either by rapid expansion or any other kind of expansion, it usually doesn't happen. There is no skeletal expansion after that age. There is usually just dentoalveolar expansion. Time required for bony filling of the sutures after rapid palatal expansion is around 3 months. Now this is something which is important. Why? Because when we place a rapid palatal expander like the Hyrax which is shown over here, the Hyrax itself will take around a week or two for the initiation and the activation. The activation schedule should be completed by 2 weeks. But if we immediately remove the Hyrax during this period, the whole arch is going to collapse. Because when the new bone is getting made, it is still very soft and pliable. We need time for the bone to ossify and mineralize and become hard, and then we are able to remove the Hyrax so that expansion that is happening because of the Hyrax will stay in position. In case rapid palatal expansion, both maxilla rotates around the point located around the frontozygomatic suture. Because these are the sutures which are most close to the area of expansion, and usually that is maximum amount of mobility takes place in these kind of sutures apart from the mid-palatal sutures. So you will see mainly movement occurring along these two sutures, that is the mid-palatal and the frontozygomatic. Can this be the last one? Functional appliances are the example of which of the following? Answer is B. Again, it's an interceptic procedure. This functional appliances, the word functional appliances means it alters the function or it makes the function better. That means function in the sense chewing, mastication, talking, etc. So again, before a full-fledged malocclusion has developed in a particular patient, we can use these kind of things so as to restore the function in such a way that something like a fixed orthodontic treatment might not have to be used in future. That's it.